Good afternoon, and welcome to healthsystemCIO.com's All-Star Panel, Targeting the Population Health of Tomorrow, a webinar tweet chat combo from healthsystemCIO.com, sponsored by Encore, a Quintiles company. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemCIO.com, and I'll be your moderator today. We are having a simultaneous integrated tweet chat hosted by our managing editor and director of social media, Kate Gamble. And all our tweet chats are using the hashtag HSCIOchat. So if you want to do some tweeting and join in the conversation, we encourage that. You can ask a question by typing it into the Q&A box in the lower right-hand corner of your screen. Leave the default set to all panelists and send those in as they occur to you. We'll get those in front of our panelists later in the program. You can download the deck using the URL on your screen, and there's a shortened URL at the bottom of all slides. And we are recording today's event. We'll have an archive ready within 2 business days, if not sooner, and you'll get an email as soon as it is available. So you see how we're going to spend our time today. We're going to go about 45 to 50 minutes. Our main panel discussion will be with Cynthia Davis, Chief Health Information Officer with Methodist Healthcare, Lisa Rollins, AVP of Population Health Informatics with Providence Health and Services, and Randy Thomas, Managing Director of Value Realization Solutions with Encore. So, without further delay, we're going to jump right into our Q&A. Cynthia, let's start with you. Can you give us an overview of Methodist? Cynthia?
Oh, my apologies. Methodist Bonner Healthcare is a 7-hospital health system in the regional West Tennessee area. We provide services and coverage to Western Tennessee, Eastern Arkansas, and Northern Mississippi. We run 7 acute care facilities, one being a pediatric facility. We have 500 employed physicians and around 2,000 community-affiliated providers as well. As a large IDN, we have the plethora of services from outpatient areas to acute care facilities to post-acute home care and hospice. We are known in the industry as a facility that has had a lot of recognition for its faith-based focus. We've done some very cutting-edge work in terms of patient and family care provision, which I'll speak to a little bit deeper as we go into the questions. And we have also a structure in place, one of the very original PHOs from the late 80s, which is a foundation. And we're also known as one of the top 100 great places to work.
Excellent. Lisa?
So good morning from Seattle. This is Lisa Rollins. And Anthony, thank you so much for the invitation to be part of this panel. I'm the Assistant Vice President of Population Health Informatics from Providence Health and Services. For those of you that may not be familiar with us, we are the 3rd largest not-for-profit health system in the United States. Started back in 1856 from 3 pioneering nuns, and I am proud to be part of the leadership team that is really committed to providing for the needs of our community, especially for those who are poor and vulnerable across Alaska, California, Montana, Oregon, and Washington. Our system includes more than 82,000 caregivers, otherwise known as FTEs. We have and serve a diverse range of ministries from birth to life, including acute care, physician clinics, long-term care, assisted living, palliative, and hospice care, along with home health and supportive housing and education for our communities. We operate 34 hospitals, 600 physician clinics, and 22 long-term care facilities, 19 hospices and home health programs, and over 693 supportive housing units in 14 different locations. So we're a fairly large organization, but with a long sense of tradition in serving the vulnerable and the poor, and our mission is to provide compassionate care that is accessible for all across the communities. And it is a pleasure to be here with you today.
Well, thank you for joining us. Randy, a little bit about Encore?
Thank you, Anthony. Good morning, and I guess getting into afternoon for some of us on the East Coast. I'm privileged to work with Encore Health Resources, a Quintiles company. We are a healthcare IT consulting and services organization focused only on the provider space, and have the privilege to work with dozens and dozens of organizations across the country, such as Providence and Methodist. So it's a pleasure to be here this morning.
Excellent, excellent. All right, let's go on to our next question, and let's start with you, Cynthia. Does your organization have a formal strategy yet for population health management? If yes, please describe it. If no, do you have a plan to define one?
And thank you, Anthony. Methodist Le Bonheur is, we're in transition as we've been long known for what I would call using a population health strategy that's more specifically a community health, public health sort of approach. We have built over time, because we do serve a very diverse and underserved community here in Western Tennessee, we've built a very strong, firm foundation with relationships through what we call our congregational health network. As many of you who either have lived or have served organizations in the South, much of the foundation for community exists through local churches. And so we've built a foundation which includes representatives from local churches in our healthcare delivery system. And through that have put together a community navigation program that we've piloted over the last 24 months. We see that as the beginning step of, first, how do we help families and patients receive the right care at the right place, and to work through some of the barriers to access to care, which ultimately impact the health of the community as well. Alongside of that, because we have had a physician hospital organization in place and a very robust physician organization for a number of years, we've used that as in a very intentional way first to begin to plan for risk-based, value-based contracting and population health. We have had the gift here in West Tennessee where we are not converting as quickly as some of you all to risk-based contracting. And so we've had the ability to take a very careful and precise approach. First one, to create an infrastructure in terms of where we are being physician-led and professionally managed, and using that approach to educate our physicians, bring them to the table to begin to deposit in the physician hospital organization some of their practice administrative data, and then to begin to serve that up and we will begin to align it to actual risk-based contracts starting in June of this year. That, I think, has been, because we've had that careful, firm foundation, it will be, as we go forward, the foundation for our additional population health initiatives. In addition, we've begun to use some external tools in which we are sharing with the practitioners who provide services in our acute care facilities their own quality and cost data. So as we use this two-pronged approach, getting the physicians more visibility into their care performance in the ambulatory practice setting, as well as their care delivery process in the acute care system. And like every organization, we're continuing to evolve and take that to the next level. So we're on our way. Are we where we need to go ultimately yet? No, but we have a very firm foundation.
Excellent. Lisa?
Yeah, so just building on what Cynthia mentioned, Providence has historically executed on what I want to call population health needs across the ministries at the local level for the last several years. But in May of last year, leadership decided that we needed a more formal infrastructure in place and created the Population Health Division within Providence. This is led by Dr. Meadows, and the goal of this division is to really maximize the health outcomes of people in the defined populations and communities within Providence Health and Services, span of responsibility through the design, delivery, and coordination of affordable quality health care. Our leadership has pulled together formerly disparate business units within Providence, and reporting to Dr. Meadows is physician services, as well as all of our contracting, our government contracting and third-party contracting, our health plan, which is based out of Oregon, as well as PACMed, which is one of the largest DoD providers in the West Coast. In addition to that, we've created the Office of Population Health Informatics, which I head up, which is really charged with population health data coordination, advanced analytics, and predictive modeling. And our role is to really be a partner with our IT department, a division, and maximizing what we have from an EHR perspective, and really creating an enterprise data warehouse that will allow us to create a more proactive care model as we move forward in this population health journey.
Excellent. Okay. Go ahead. Somebody want to jump in?
No, I was just going to say that's a very broad description of what we do, and hopefully I'll provide a little additional detail as we get through the list of questions.
All right, very good. Now, before we address our next question, we're going to run an audience poll. So I'm going to share this poll with you now, and it's just a yes or no, so go ahead and answer it. You should see it on your screen now. Do you have a population health informatics roadmap? So go ahead and answer that poll as our audience is, as our speakers are responding, and then we'll discuss your answers. So, Lisa, let's start with you on this one. Regardless of where your organization is on integrating population health management approach into your overall framework of care delivery, are you starting to think about how the informatics needs of the organization might change as you begin to pivot into this new world? So informatics needs changing. Lisa?
Yes, so Anthony, that's been my charge over the last year, is really figuring out where we are and what we need. And as we start to define a more proactive care model around population health, the informatics and data needs really span the whole care continuum. Historically, the industry has really operated more from a siloed approach that, you know, I'm in primary care, so here's my data around primary care. Here I am in behavioral health or outpatient or acute care. But we've approached population health and the informatics needs really from a visual. If you could imagine population health being a vertical line, and then the intersection of that vertical line, horizontal lines that represent the typical encounter with a healthcare delivery system, a visit to your physician's office, a visit to a behavioral health specialist, a visit to the acute care environment or tertiary or quaternary, a skilled nursing facility, a long-term care facility, and a palliative care service. Imagine, if you will, the white lines or the white spaces in between those horizontal or in between those vertical lines then that's where we need to be able to collect data on what's happening with that patient throughout that whole care continuum. And your EHR data is certainly a source of truth from a clinical perspective. But you need to be able to augment that data to really create a patient profile that would include social determinants that affect health status and health care outcomes. You also need to be able to understand what's happening with that patient outside of your environment, and through the utilization and coordination of data exchange between HIEs, it helps you to see how that patient's being treated within the whole community. And on the other side of that is, once you've collected all this informatics data, the value of it is tremendous in regards to creating that patient profile, translating that patient profile into a personalized care model, but being able to then advance in using that data to drive community and state and federal policy based on your understanding of that population, I think brings tremendous value even outside of the healthcare delivery system.
Very good. Cynthia?
And I want to build on the excellent framework that Lisa outlined, because it certainly is a journey. We think in terms of informatics in really four discrete work streams. First is the consumer portion, and in Lisa's language, that would be, keeping our focus on how do we aggregate and understand that person-level information across the continuum of care, whether they be in the physician office, in a post-acute care setting, in an outpatient surgery center, or buying drugs at Walgreens. And then the second key work stream is, and we have a deep relationship with the University Tennessee Health Science Center. In fact, our standing up an enterprise research data warehouse, which has been one of our opportunities to begin to aggregate data and transform data into wisdom, to use the famous term. And then certainly operational informatics. Are we providing the folks in the variety of venues, and we're not unlike a lot of health systems across this country. We are at that juncture where the physician offices, the primary care physician offices have their data set, the specialist physician offices have their data set, the hospital has its data set, and it will be our opportunity first to begin to aggregate and transform that information in a way that's going to allow us to support the day-to-day operations. Certainly, as we've put in these EHRs across time, they've been great in helping us to gather a lot of transactional information, but I've long been an advocate of they have not been the tools to be able to begin to bring to your frontline staff or to your physician leaders without some additional effort the information they need, certainly real time as to what's going on with readmissions. Methodist Bonner was actually the first organization to develop a sepsis alert, which was then ultimately provided to one of the very large EMR vendors. But those are the kinds of things that we are thinking about in terms of how do we, as we begin to cycle faster and further, how do we get that real-time clinical and operational information into the hands of our leaders and into the hands of those clinicians who need to make care delivery decisions. And then fourth would be, I would say, also financial analytics. How are we, and I use that term carefully, how are we managing those managed care contracts that are coming our way, and understanding the value proposition of both. For the dollar, are we providing the most cost-effective yet providing the right clinical outcomes for our patients and our population? One of our early activities we did in partnership with the University of Tennessee Health Science Center was to stand up a small data mart focused very much in West Tennessee. We have a very high prevalence of diabetes and hypertension. And so pulling that data together from different venues of care and then transforming it and being able to present it back to the clinical team was one of the use cases for us then to begin to staff a community navigation program, which allowed us to, in a very tightly managed arena, be able to identify patients who are at the greatest risk, so then the risk stratification process, and then focus on, and I'm thinking of a specific patient and family instance where barriers to transportation and barriers to being able to purchase medications was causing a lot of readmission activity. So it's important as we're thinking about informatics, it's not purely about the data, it's also about once you discover those trends within the data, how are you helping the organization be able to break down walls and then be able to address certainly a lot of the access to care as well as social and economic requirements in order to be able to pivot and change the world. And last and not least, and I do connect this back to consumer informatics, we've been big early users of beacons to be able to, first of all, track and understand within the population where folks are going to reach care, and actually through some of our mobility solutions, if you drive by one of our urgent care or minor medication center in the flu season, you begin to get information delivered to you that's tailored and specific, as well as a reminder to flu management.
Excellent. All right, Randy, before we bring you in here, I'm going to share the poll results, which you should see on your screen. We have 37% of respondents who have an informatics roadmap. The vast majority, 63%, do not. So your thoughts on that, Randy?
Well, I think that both as Cynthia and Lisa are describing, we're early stages as organizations are figuring out first and foremost what their population health management approach is, and in many cases it's evolving organically out of philosophies of approach to care. But in areas where we're seeing higher penetration of at-risk contracting arrangements, the need for access to information to be able to understand where to focus attention across populations organizations are at risk for, that need for information and the urgency for that need for information really, we would say, really requires a deliberate approach and not sort of happenstance. So being able to understand what capabilities an organization currently has relative to deriving knowledge about the populations they're at risk for, and then being able, very much to Cynthia's point of real-time intervention, being able to provide that back particularly into the patient-centered medical home model, to the care coordinators to be able to do appropriate outreach to patients. That all needs to occur rather deliberately. And so as organizations are assuming more and more at-risk types of arrangements, the need for a roadmap, I think, is going to increase.
Very good. All right, Lisa, let's go to you on this one. Do you currently have any active projects focused on providing IT support to specific population health management needs? And some more details, whether or not you say yes or no. So your thoughts?
So the big answer is yes. Right now at Providence, about 30% of our patient population is tied to an at-risk contract. So we have several employer-based ACOs with both Boeing and Intel, as well as Medicare Shared Savings ACO, and about 3 other ACOs currently in place. And with that, we felt as Randy had mentioned, we really felt the need and urgency to tee up a care management, care coordination platform that was EHR agnostic and would provide for bidirectional pull and push of clinical data from disparate EHRs. So imagine, if you will, if you've got 7 different ACOs, and with those ACOs, we're partnering with providers that are not part of Providence. And because of that, you know, we have access to claims data. So we needed a population health module that would ingest, for lack of better terms, the claims data, as well as the clinical data that we had access to from our Epic implementation. Pull that data up, risk stratify that data so that we could focus our resources on the highest, the population with the highest need from both a care management perspective and utilization perspective. So we've executed just recently on that and focusing heavily on that high-risk population. But our long-term goal is, as we execute this care management, care coordination platform across our entire enterprise, that we will start to integrate the remaining population, where once we get the data into that system, we'll understand better where there's opportunities to improve upon the health status and health outcome of our populations.
Very good. Cynthia?
So we have a couple of work streams in flight. First, we are not unlike Lisa. We have a data aggregation tool. It's based out of our physician hospital organization, and they capture data from the acute care setting, but also all of the non-employed and employed physicians affiliated with our PHO. They also get a data feed from one of the major payers, and so by aggregating and then serving that information up, the process of reviewing that, and you know, it's to be perfectly simple, it's a scorecard that the practices review once a month, and as we move into risk sharing, it'll be there'll be more of a carrot and a reason for them to review the information and act upon the information. Now, it's not real time. That's the next leg in our journey. On something that we're doing more focused on the employed physicians as well as the acute care practitioners is that we're using the power of mobility to begin to bring some real-time alerting into their workflow, first of all for potential readmissions, and the second of all for consults and results for lab tests. And we're doing that through our electronic medical record and a secure texting tool. And the response from the physicians has been extraordinary. Usually it's one of those things where, you know, when you really create a carrot that adds real value, everybody wants to come. And our bigger challenge has been, you know, being able to keep up with the demands for getting folks set up, which it's a pretty quick process. It's a wonderful opportunity. And so, and then the third piece, as I talked a little bit earlier about, we continue to tune and build on some of the real-time alerting that we have for septicemia. While we were the original creator of a real-time sepsis alert that went in to call through our EMR database and serve it up, we continue to tune it one for pediatric populations as well as the acute care population. So one of the things I'm currently thinking about going forward as we look at, you know, one of our biggest challenges with all of the massive amounts of data is to, you know, how do we improve both our governance of that information and the quality and the cleanliness of that information.
Nice. Very good.
Thank you.
Cleanliness is important in the healthcare setting, right? Very good. Randy, let's go to you on this one. Why will what got you here not get you there when it comes to population health management tools and strategies?
Well, I think one of the biggest challenges is something that Lisa touched on, which is from an IT perspective, this goes beyond the walls of your facility and even beyond the bounds of the broader healthcare organization. So there are a number of just really pragmatic challenges around from a data management perspective in how you're going to bring together the information, both from an analytics perspective and as well as to create liquidity for that data to address the needs as Cynthia described, to provide information to providers in more real time. So we may need to be thinking broader than both Lisa and Cynthia alluded to this, thinking broader than the very important capabilities within the EHR, current EHRs, because you're going to have to provide connections for patients that are going to bring together their patient information across disparate EHRs. You're going to have to, at the base level, you're going to have to be aggregating data together, and you're going to have to be supporting in various provider offices access to information around so that they can intervene in real time. So it really requires a broader perspective and a level of collaboration with other organizations, and even a different approach to how you think of your application portfolio.
Very good. All right. We're going to do another quick poll now, and then we'll address our next question. So let's get this out to our audience. The question is going to be, do you have an executive charged with responsibility for population health management? And you should see that in front of you right now. Do you have an executive charged with responsibility for your population health management? So with that question in mind, Cynthia, let's talk about that.
So are you asking me what it will take from a leadership perspective to be successful in population health?
Right, yeah, let's go with the question on the screen. Sorry about that.
Okay. Yeah, no worries. So I think, first of all, it's a new mindset. I think Randy and Lisa both spoke to thinking more broadly than our walls, and it really is, how do you develop collaborative partnerships both in your healthcare facility, with other healthcare facilities in your region, with universities, with drugstores, with your physician practices. And most importantly, it takes leadership to do that, and it takes good, strong governance, and then a focus on, what is really do you want your care process model to be in this new world of population health and value-based care.
Very good. Lisa, your thoughts?
Yeah, so I'm going to quote my CEO, Rod Hotchman, and he recently said at a healthcare summit that we'll know that we have succeeded in population health as a service delivery system when our primary focus is on health rather than health care. And so as we all travel down this journey together to a value-based purchasing society and system, we're really flipping our historical business model on its head. It's no longer the heads in the bed business model, but how do we maintain and keep our patient population healthy so we can reduce the instances a patient comes into the ED or for acute care and or tertiary care. And that's really going to take a tremendous change management directive from leadership all the way down. And it's going to take more than just your typical change management, because as we create this proactive care model where we are actively engaging with the patient in managing their health, and this is not the old HMO business model where we were focusing on cost and utilization, but truly on health outcomes and health status. It's going to take a variety of different, leadership's going to have to to address a variety of different issues, from a change management perspective, as well as helping to educate our caregivers on a new care model and what does it mean to provide proactive care. You know, currently, if you go in to see your primary care doctor and you have been diagnosed with high blood pressure, typically you get a prescription and they advise you, you know, you need to do this or you need to do that to help lower your cholesterol or your blood pressure. What we'll see in the future as healthcare teams are dispersed to support the physician care team, we'll start to see more goal setting in healthcare, and that as your partner in healthcare, we help you to attain increments in the goals we've established to address the overall health issue that you're concerned with or that you've acquired. So it's going to take a tremendous amount of rethinking our business model, both from an administrative perspective as well as from a clinical perspective. I know we've been bouncing around some ideas around creating a population health academy to help execute on the mission and vision of Providence. And with that, it's moving more toward, you know, the focus on the consumer. I know as my mom went through our healthcare delivery system, you know, whatever the doctor or the nurse told her to do, that's what she did. But with the new generation, it's all about consumerism and how can we more effectively provide healthcare services that are convenient, timely. I know we've been deploying a multitude of strategies around telemedicine, partnering with Walgreens to have access to primary care services at the convenience of the patient and not at the convenience of the provider. So our strategy from a leadership perspective is focusing on that consumer and how we pull everyone together to have the same mission and goal in creating a healthier community.
Excellent. Thank you. All right, now I'm going to share the poll results, and then we will discuss them. I'd like to get Randy's reaction. Randy, we see 62% have an executive charged with responsibility for population health management. 38% do not. So do those numbers surprise you, and what are the implications of folks that do not have someone in charge of it?
Well, actually, it is a little surprising and great to see, because I think, you know, organizations need, if they're going to be successful in executing a strategy on population health management, there needs to be appropriate leadership focus on that. But I would also say that for those organizations that don't yet have an executive charged with this responsibility, it's likely because of the market is different in their area. I mean, the distribution of risk-based contracting that's really pushing a lot of organizations to be aggressive in how they address population health management, that's unevenly distributed. And so I would imagine that this distribution of 62-38% is going to start shifting into, you know, well north of 80% as the population health at-risk contracting models penetrate other parts of the country.
Very good. All right, before we're going to move on to our next question, I want to remind our audience that if you have a question, go ahead, send it in now in the Q&A box, the lower right-hand corner of your screen. Leave the default set to all panelists, and we'll take a look at those. We have about 10 minutes left in our program. Let's go with Cynthia on this. Cynthia, is this an area where it's difficult to find the people you need because of the specific and unique skill sets required?
Oh, absolutely. I call it the new Ehr shortage. Mm-hmm. And what we're doing at Methodist is kind of a multi-pronged approach. First of all, we're investing in physician leadership training for our young and upcoming physician leaders. And typically, our CEO of our health system invest in a year-long course for about 15 to 20 physicians, and it's been, I think it's already reaped wonderful rewards. One of the projects that I spoke of earlier, providing the acute care physicians with dashboards and scorecards around their cost, quality, and resource utilization is being championed and led by one of the staff, the physician staff who took that coursework. Second, we in Memphis, it's also the home of FedEx, and so we, have wonderful partnership with FedEx because they're extraordinarily strong in data analytics, and there's a lot of effort and focus with several of the local universities to grow those skills in the staff. But, and for example, in order for us to recruit, we basically recruited several data scientists, sent them off to university, and have worked, as they've gone through coursework, they have a position as they graduate. And then, folks who work, we're retooling part of our EHR staff, training them up to really have a stronger footprint in terms of analytics. And for an IT organization, that's also a huge culture change for that staff as well.
Okay, very good. Let's move to the next question in the interest of covering some more before we finish. Lisa, let's go with you on this. What are your thoughts on macro and the implications for population health? Do you think it's a positive step?
So let me start off by applauding CMS for actually aligning the multiple programs they had out there into one single program called MIPS. So I've been advocating, we had PQRS, meaningful use, multiple different incentive programs. There was a lot of overlap in regards to what we were measuring or what we weren't measuring, and so I'm grateful to see that CMS has now sort of wrangled, for lack of better terms, all those programs under MACRA. But with that, it's really creating accountability for the providers to focus on health status. Again, this is not the HMO world where we were focused on utilization and cost, but really focused on health outcomes. And it's an aggressive move. I've heard comments from our team that it wasn't aggressive enough on one side, and some felt like it was too aggressive. But in the middle, I know that CMS, as the regulatory body, sort of settled in the middle in regards to the proposal. It's a great opportunity, I think, for us to expand upon really creating that proactive care model that I spoke of earlier. But it is a challenge, especially with a system the size of Providence and trying to pull together all of our 4 instances and 4 versions and 6 instances of EPIC and trying to define what our true level of performance is. So it's creating some challenges that we anticipated, but I think we're well poised as an organization to come to the table with some well thought out policies and procedures around executing on a high performing MACRA program.
Very good. Randy, let's go with you on this one. What are the dangers of falling behind? I mean, you get yourself in a position where you could really sort of not be there and then not be in position to qualify for the reimbursements that you need to. Just what are your thoughts there? I don't want to scare people, but.
Sure, Anthony. I think, and I'm going to use a specific example here, and it has to do with the shift toward electronic clinical quality measures in the CMS programs, and we're seeing in the commercial contracts as well. And because reimbursement gets tied to those clinical quality measures, and those measures are calculated using data captured in the course of care in EHRs, not data that was manually abstracted with nurse abstractors going through the records, organizations can realize a different sort of level of performance because of data issues related to reporting these electronic clinical quality measures. And typically, what you see is that it's not an issue in performance and clinical performance, it's an issue in workflow and how that data is captured, which means you've got to change workflow, change system configuration to get the data appropriately captured so it flows through so you get the proper recognition for the level of quality performance in the organization. Well, that is not a small change to make in an organization. So just that one example, getting on top of that kind of an issue now, I mean, you might need a runway of at least 12 to 18 months to sort of write that, or to change that workflow and get that well accepted across your organization. So I think organizations shouldn't underestimate the level of effort it's going to take to even make that one kind of change related to having the right data to support your ECQMs, to support your incentive-based contracts, and that a lot of that is also going to relate to cultural changes in the organization as this whole thought process shifts to thinking about populations rather than transactions, so transactions of care. So I think even in areas of the country where at-risk contracting arrangements aren't as prevalent, the time is now to start looking at these issues so that you're well prepared for when the changes do occur.
Very good. All right, Cynthia, let's squeeze in one last question here before we close up the event. Any thoughts on common mistakes, pitfalls, roads that people could be exploring that you have found, or dead ends? Thoughts about that?
I think when an organization focuses first on technology and sparkly baubles instead of the basics of, thinking outside of the box, to use a kind of a canned, corny term, and making sure that they're paying proper attention to process. I think Randy made a great point. You've got to make sure that, it's often where in the process are you capturing the right information at the right time. I think those are things that I have experienced during my journey. Don't focus so much on the technology. Yes, it's important, but it's really more about let's look at the process. Let's make sure we have a strong change management process, and frankly, it's all about leadership. Excellent. Well, that is about all we had time for today. What an excellent event. I enjoyed the tweet chat, and the polling was very interesting. So I want to thank everyone for participating. When you closed out your WebEx window today, you're going to see a post-event survey. Take you less than probably 30 seconds to answer, and we would appreciate it if you did so. I want to thank our panel, Cynthia Davis, Lisa Rollins, and Randy Thomas, and I want to thank Encore for sponsoring today's event. As I mentioned, you'll receive an email when our archive is ready and posted to our YouTube channel. For those of you who have the CHIME CHCIO certification, attending our webinars gets you 1 CEU, so let CHIME know you were here. If you've asked us to let CHIME know you were here, we'll do that. Sponsorship opportunities, contact Nancy Wilcox. And if you need a certificate of attendance to show you were here, you can use the final slide in this deck. And you can go to our website to view our upcoming schedule of events. So again, I want to thank our panel, our attendees, Encore, and everybody have a wonderful day. Thank you.